Hello, everybody. Do you know who I am? Do I have to introduce myself? So if you don't know me, Hala. I'm one of the second-year fellows. You can call me Nas. Today I'm going to be talking about asthma phenotypes. So asthma phenotypes, if you look through those, like there's a lot of information out there, but we're going to focus on certain things that will help us in terms of managing our patients. Number one is going to be recognizing what severe asthma, severe and uncontrolled asthma is. Number two is going to be understanding the type 2 or like T helper 2 inflammatory pathway in asthma. That's the main driver in most asthmatic patients. We're going to talk about phenotypes. So if you look for asthma phenotypes, some of them are clinical phenotypes and some of them are inflammatory phenotypes based on the T2 inflammatory pathway, which I will be focusing more on because that will guide our treatment and what we can choose for treatment going forward. We're going to understand the importance of phenotyping in managing those severe uncontrolled asthmatics. And we're going to touch quickly on some of the FDA-approved biologic agents for treatment of severe asthma, okay? With that, I'm going to start. Asthma is a Greek word. It means short-drawn breath or death rattle. It was described as a complication of epilepsy caused by phlegm coming from the brain, lodging in the lungs, and blocking the airflow to the body. Probably this is why we get a lot of stroke patients. So basically, it's not a single disease. It's a variety of clinical presentations. It has physiological characteristics, outcomes that are also variable. And to better understand this heterogeneity, the concept of asthma phenotyping has emerged. Okay, so what is phenotype? What is a phenotype? What is the definition of a phenotype? Anybody knows? Okay. So if you take the thesaurus, if you look it up, it means observable properties of an organism produced by interaction of the genotype and the environment. Or simply, genotype plus environment equals phenotype. So I'm going to touch quick about it. I'm going to tell you a little bit, like we're going to go over a quick history of asthma that will help us kind of understand why the interest in phenotyping started and kind of like became apparent and gained traction. So basically in the 17th century, Fuller described association of symptoms with regions and triggers, allergic asthma, and then late 19th century, Stedman's textbook offered removal of these offending allergens will help asthmatic patients. In the 1940s, the theory of extrinsic and intrinsic asthma emerged, which is like extrinsic is allergens from outside the body versus changes inside the body that can cause asthma. And then in the 50s, use of systemic corticosteroids was gained mainstream to prevent and treat asthma exacerbation. In the 70s, the inhaled corticosteroids were introduced. In the 80s and 90s, the T helper 2 inflammation or type 2 inflammation was noted regardless whether you have like allergens or atopy. And then the 2000, the biologic agents started emerging in treatment of asthma. Okay, so that is a nice diagram. And as there are like more advances, you see the interest in phenotyping asthma started. So in the past, we used to say, oh, extrinsic, intrinsic asthma. And there was eosinophilic inflammation that was noted. And then now we think about it as TH2 high asthma, TH2 low asthma, and clustering and all of that. Okay. So back to phenotype. So this is the clinical, in a way, that is the clinical phenotyping. It's called the best thing that can describe it is the SARP clusters, which is, SARP means it's the Severe Asthma Research Program. It's an NIH-funded group. It has several locations in the country. So in one of their major studies, what they did is that they kind of recruited around 700 subjects, asthmatics, pretty much non-smoker, kind of like did extensive questionnaires with them, PFTs to get like their FEV1, FEV1 over FVC and all of that. And after they got all that information, they tried to come up with clusters that are similar, clusters of patients that share similarities. They found mild, moderate, and severe, 3 groups, mild, moderate, and severe atopic asthma, and then a 4th group that was mainly late onset, obese, tended to be female, moderate FEV1 reduction, frequent corticosteroid use. And the 5th group had like almost like a fixed airflow obstruction, was very COPD-like. Okay. They further can like try to remove many of the variables and can like try to narrow down things. So the way, if you want to look at the way they cluster things, they based the patients on baseline FEV1, and then based on that, their maximum FEV1 after bronchodilators, and then later here the age of onset, and they came up with all these clusters. And I'll talk about what these things mean. Just like keep the colors in your head. Okay. So pretty much cluster 1, according to that study by the SARP group, it's mild allergic asthma, early onset, atopic, normal lung function, pretty much not that much controller medications, like minimal healthcare utilization. Group 2 is the mild moderate allergic group, early onset atopic. They had like baseline FEV1, but it would reverse to normal. Group cluster 4, I don't know, it's not cluster 3 by then, but it's cluster 4. It's the severe allergic asthma. They had severe decrease in FEV1, but it could reverse to near normal. It was high healthcare utilization. And then you have cluster 3 and cluster 5. Cluster 3 is a severe older onset asthma, high BMI pretty much. And then the cluster 5 was more of like the less airflow, like less reversibility in their pulmonary function testing. Okay. I'm going to touch on this also real quick. So basically that first study that they tried to kind of cluster the patients and come up with somewhat of a clinical phenotype, they didn't take inflammatory markers like eosinophils and the sputum, like in the blood, other inflammatory markers that can indicate the severity of asthma. So a second study was made, examined 400 patients from the database. They had clinical physiologic data, and they also underwent bronchoscopy, BAL cell count differentials, allergy skin testing, and measurements of fraction of the exhaled nitric oxide and IgEs. And pretty much they came up with 6 clusters, with the one being normal. I'm not going to expand on that. But basically the difference was the recognition of a late onset highly eosinophilic cluster. Now, what I really want to focus on during this lecture is phenotyping based on the biomarkers of inflammation. And why I want to do that is that because it's going to be most helpful in guiding further management for your patients. So if there's something that you'll get out of this lecture, I'm like, okay, how can I change my patient's management? Understanding the basics to the biomarkers of inflammation is a really important part of it. Okay, so here comes the confusogram. So for asthma, you have like type 2 inflammation, which is like an antigen, allergen, activates the CD4 T helper 2 cell, which ends up secreting IL-4, 5, and 13, which end up causing the maturation of B cells into plasma cells, secreting IgEs, and then that like attaches to the mast cells, releasing inflammatory mediators, and then like eosinophil activation, and then like you have the hyperresponsiveness, remodeling, and mucus plugging that you see with asthma. And then there's the 9 type 2 inflammation, more of like what we call a type 1, more neutrophilic macrophage-based inflammation, where you have interferon alpha and gamma. Sorry, not gamma. Interferon gamma and TNF alpha. So just like a touchback on immunology, if you can remember. So T helper 1 is macrophage neutrophil, phagocyte-dependent inflammation. T helper 2 is allergic response resulting in production of interleukins 4, 5, and 13. Those are really have major big role in asthma. Okay. So pretty much this is a nice way of showing the type 2 inflammatory pathway. So IL-4 and 13, they induce B cells to produce IgE. IL-13 induces epithelial cells to produce periostin. We're going to talk quickly about this in an upcoming slide. IL-5 promotes the proliferation, differentiation, and recruitment of the eosinophils at the site of inflammation. Okay, another confusogram. This is actually a kind of, we talked about clusters earlier. This is a nice way that I was able to kind of like put together everything and kind of like, you know, in terms of like splitting in my head. So here you have the type 2 inflammation, type 2 high, atopy, allergy, early onset, eosinophilia. It's responsive to corticosteroids versus the type 2 low or type 1 high, which is later age, neutrophilia, T helper 17, and like related to obesity and severe asthma. Okay. So just to contrast the two types of inflammation that you see in asthma. Type 2 high, which means it's T helper 2 cell driven, it's more eosinophil activation, high IgE levels, IL-5, IL-4, and IL-13. You have biologic treatments available for that, and we'll talk about this. It's associated with a good response to corticosteroids. Now the type 2 low, or what is called type 1 high, it's T helper 17 driven, neutrophilic inflammation plays a big role. Obesity may be related to the chest wall biomechanics and airway compliance. Some people are smokers. Questionable role for biologic treatments, even though a lot of biologic treatments are being investigated, and it's usually refractory to steroid treatment. So some of the inflammatory markers, like if you read the studies and pretty much you're going to come across those fraction of exhaled nitric oxide. Usually nitric oxide synthetase is upregulated by IL-13, associated with worse asthma symptoms, need for corticosteroids, and predictive of responsiveness to corticosteroid therapy. Then you have sputum eosinophils. It's technically difficult to measure. And the next good thing is blood eosinophils. And I highlighted that because it's a simple, easy tool that you can use in your clinic. It's been linked to elevated type 2 cytokines in the airways, largely replaced sputum eosinophils as type 2 biomarker. And there's periostin, up and coming, extracellular matrix protein induced by IL-4 and 13, associated with sputum eosinophilia, T helper 2 inflammation. It's still uncertain. The utility of it as a response marker, but it's under investigation. So, are you guys confused, yes or no? So we're gonna try and put whatever we talked about into actual practice, like how can I use what I learned so far? So whenever you talk phenotyping in asthma, you're automatically thinking about severe asthma. We're not talking about like the mild asthma that you can easily manage. If I'm starting to think about, okay, I want to phenotype my patient, it means like they're failing the mainstream, like the standard therapies, and I want to try to figure out if there's something more I can offer for them, okay? So number one, confirm a diagnosis for asthma. If you have a uncontrolled asthmatic, just like always take a step back and figure out what could mimic this asthma. What if it's not asthma? What if it's something else? Some of the asthma mimics, you have airway diseases like COPD, bronchiectasis, anatomic lesions, endobronchial lesions, tumors, foreign bodies, vascular problems like PE, Church-Strauss, upper airway problems like vocal cord dysfunction, cardiac like CHF, allergic bronchopulmonary aspergillosis, adverse drug reaction, hypereosinophilic syndromes. So after you think, okay, I have like this patient who has like super severe asthma, they're actually really asthma, it's not like something else, then your next step is going to be, how do you tease out and differentiate a severe asthma from a milder asthma? So you have to have like certain criteria in your mind. So any asthma that requires treatment with guideline-suggested medications, steps 4 and 5 in GINA, which is high-dose ICS and LABA, Licotriene modifier, theophylline for the previous year, systemic corticosteroids over 50% of the previous year to prevent it from becoming uncontrolled. And despite everything, it remains uncontrolled. So that is a very severe asthma definition, okay? And those are steps 4 and steps 5 in the GINA recommendations. Okay, so I would stop here just a second and think about certain things. Like whenever you have an asthmatic patient, they're uncontrolled, you confirm it's asthma, it's very severe, they're on high dose inhaled corticosteroids. So you have to, before you move to the next step and say, okay, what can I add for their treatment? You have to make sure at least like you covered everything in the sense of, you do your patient education, you have your asthma action plan for the patient, their peak flow meter, they can monitor their symptoms, assess their adherence to medications. Are they actually taking these medications? How often are they taking them? Are they forgetting their controlling medications? Like, oh, I only puff Advil whenever I remember it. Explore their inhaler techniques, see how are they actually using that properly, and control any triggers. In terms of controlling triggers, I actually have an asthma clinic patient. The way he's living currently, like he lives in a room that's close to the boilers, and there's like a lot of stuff that come up that aggravates his asthma, and he's unable to change that. So for him to gain better control of asthma, ideally it would be removing that trigger.
Well, sometimes doctors make mistakes, and you try twice as hard to fix them. You're using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. You might show me how your inhaler works.
Well, make sure your asthmatic is not using their inhaler as a perfume. Okay, so step 3, like what we talked about, is we confirmed it's asthma. Oh, I have a patient who's severely asthmatic. Is it asthma or no? Oh, it's asthma. Number 2, is it a severe asthma or moderate asthma? And oh, it's a severe asthma based on the criteria we talked about. And now number 3, we're going to define uncontrolled asthma. Okay, so uncontrolled asthma, what is uncontrolled asthma? Does anybody know? Okay, nobody knows. At least one of the following: poor symptom control based on the asthma control test less than 20, or asthma control questionnaire, not well controlled by the GINA guidelines, frequent severe exacerbations, 2 or more bursts of systemic steroids, like getting like the prednisone 40 for 5 days in the previous year. If they had serious exacerbations like hospitalization, ICU stay, mechanical ventilation in the previous year, and then they have airflow limitations, like after appropriate bronchodilator withhold, their FEV1 is less than 80% of predicted in the face of reduced FEV1 over FVC. And any controlled asthma, that if you taper the medication, it becomes uncontrolled. So that goes under the uncontrolled asthma criteria, okay? We're good so far? Okay. Just quickly, high-dose corticosteroids. This is a nice small table. It kind of tells you what qualifies as high-dose corticosteroids. For example, if you're using Symbicort, budesonide, like over 1,600, and then like Adavir, if you're using fluticasone, it's over 1,000 per day. Okay, back to the confusogram. Just keep that in your mind because that will guide our phenotyping and further treatment for the patients, okay? We have cases, we have some interactions. Case number 1. So Selena is a 20-year-old woman. She has a history of asthma that was diagnosed 10 years ago. It was diagnosed through pulmonary function testing. She had 2 visits to the emergency department in the last year, and she was treated for exacerbation with bronchodilators and oral prednisone. She reports symptoms consistent with severe persistent asthma while taking Adavir 550 microgram, 2 puffs twice daily, as well as singular 10 milligrams daily. Skin testing is positive for 2 species of house dust mites, several molds, and pollen. The total serum IgE level is 436 international units per milliliter. Okay, so how can you treat her asthma better? Pembrolizumab, Omalizumab, Inflammatory, confusumab. What do you guys think? Who goes with 1? Thank God. Who goes with 2? Okay, who goes with 3? Okay, who goes with 4? It is actually 2, Omalizumab. So let's go through the stepwise approach that we talked about. Number 1, confirm it's asthma. It was actually like she was tested through like a pulmonary function test and it was confirmed it was asthma. Number 2, differentiate mild from severe asthma. She's already on high dose inhaled corticosteroids as well as a LABA, and she's on singular as well. So that is severe asthma. Step 3, define uncontrolled asthma. Hers is uncontrolled because she's still symptomatic. She's still waking up at night. She's still using albuterol. She had about 2 exacerbations with oral steroids last year. Okay, so how do you phenotype this woman? What do you think her inflammatory phenotype is? Perfect. Can you narrow it down? Is there like a certain thing in
Early onset
IgE? So it's phenotype 2 high, as Hafsa said, and it's more of like atopy allergy, which also goes under the T2 high phenotype. And for that, we use Omalizumab, which is an anti-IgE monoclonal antibody. It's FDA approved in 2003 for severe allergic asthma. It binds the circulating IgE regardless of specificity, so whatever IgE, it binds it. It forms small biologically inert Omalizumab IgE complexes, and it does not activate the complement. Usually the way you dose it, it's weight-based, and you have to have your IgE level as well, because like based on that level, you're gonna give the dose. So what's the mechanism of action? As we said, it binds all the IgEs out there. Who would benefit from it? Moderate to severe persistent allergic asthma. IgE levels, usually this is what you're looking for to get it approved, 30 to 700 international units per milliliter. Positive allergen skin or specific IgE tests to perennial allergens like dust mites, roaches, dog, cat, dander, all of that. Frequent exacerbations of asthma. Actually, there are a couple studies. Usually we don't fully rely on that, but what they found is that better response to Omalizumab would decrease exacerbation when your eosinophil count in one study was over 300 and the other was over 260. And what it does, it basically decreases the rate of exacerbation. It decreases the amount of exacerbation that a patient has. It doesn't change FEV1. It doesn't change the use of rescue medications. This is what they found in this study back in 2005. It just decreases the amount of exacerbation that the patient would get. Now, case 2. Gerard is a 55-year-old man, history of asthma. He's on Adavir 550 micrograms twice daily, as needed albuterol, which he uses 3 times on a daily basis. He's also on singular. He was admitted 3 times in the past year for asthma exacerbations. During one admission, he required BiPAP for hypoxia and respiratory effort. His total IgE is 19 international units per milliliter. Blood eosinophils are 350 per microliter. Okay. So how can you treat his asthma better? Pembrolizumab, Omalizumab, Mepolizumab, or confusumab? Who says 1? Good. 2. Good. 3. 4. It is Mepolizumab. So to go quickly to reevaluate him quickly, confirm it's asthma, differentiate it from severe, differentiate mild from severe, which he already has severe, define uncontrolled, like the symptoms, exacerbations despite maximal treatment. Ooh, what type is he? What type? How do you phenotype him? Oh, you guessed it, guys. Type 2 high. It's more of an eosinophilic, okay? So for eosinophilic asthma that doesn't have elevated IgEs, we have like two classes of drugs that are FDA approved. There are like many that are under investigation, but the ones that are approved and widely used, we'll talk about them this time, this lecture, sorry. So you have anti-IL-5 and anti-IL-4. So the anti-IL-5 drugs are Omalizumab, which is Nucala, Inflammatory, and benralizumab, which is IL-5 receptor antibody. So Omalizumab, what is it? It's a humanized monoclonal anti-IL-5. The way you dose it is 100 micrograms sub-Q every 4 weeks. It's FDA approved in 2015. To qualify for it, your patient has to have peripheral eosinophils over 150. And there were many studies. If you look at Omalizumab, there were many studies that are done, but I'm just going to mention some of them, like what we really found out from those. What it does is basically significantly fewer severe exacerbation in comparison to placebo in this study over a course of a year, and that was statistically significant. And then mean rate of clinically significant exacerbation in the study was significantly less in people getting Omalizumab in comparison to placebo, as well as change from baseline in FEV1, which was more pronounced in the Omalizumab arm in comparison to placebo. It was studied as a sparing oral glucocorticoid sparing agent. And there was, in this study that evaluated the reduction in oral steroid use, the patients on Omalizumab had more significant reduction, about 50% in comparison to placebo. Okay. The second one is, it's kind of interesting from what I read is that Omalizumab early on in the 2000s, it was given to, studied and given to all asthma patients out there. That was before they started splitting up people as like eosinophilic asthma, neutrophilic asthma, atopic asthma. So it seems like initially it was like studies were disappointing and it didn't show any significant change. However, what they noted is that people with higher eosinophil counts in their sputum and their blood, they tended to benefit more from it. And then the further studies that were done actually focused on people with certain cutoff of their peripheral eosinophil count. So the second one is Inflammatory, monoclonal antibody against IL-5, reduces reproduction and survival of eosinophils. You have to have peripheral eosinophilia over 400 per microliter in order to qualify for that drug, and it's weight-based. And it's taken once in every 4 weeks. So many studies that evaluated Inflammatory, like the treatment arms, experienced significant reduction in frequency of exacerbations and significant improvements in FEV1. The last one is benralizumab, which is a humanized monoclonal antibody against IL-5 receptor. Depletes IL-5 receptor-bearing cells, eosinophils and basophils by enhanced antibody-dependent cytotoxicity. It's administered sub-Q every 4 weeks for the first 3 doses, and then once every 8 weeks. And you have to have eosinophils over 300. Again, in this study, it significantly reduced medial median final oral glucocorticoid doses from baseline by 75%. So it was good for sparing patients from oral corticosteroids. Every 8 weeks, it resulted in annual exacerbation rate that was 70% lower than the rate with placebo, which is good for somebody who has like severe asthma. Again, annual exacerbation rate is significantly lower whenever you take that medication. Now we talked about the IL-5 drugs and then anti-IL-4. We have dupilumab, which is a human monoclonal IgG that binds to the IL-4 receptor alpha subunit, inhibits IL-4 and 13 signaling. The initial dose is 400 milligrams, 200 milligrams injection or 600 milligrams. And then maintenance is 200 milligrams or 300 milligrams once every other week, once every 2 weeks. Obviously, it showed reduction in exacerbation rate, time to exacerbation. Just to summarize all 4 of them and what they're cut off for peripheral eosinophilia. So just quickly to recap, mepolizumab, peripheral EOS have to be over 150. Benralizumab has to be over 300. Dupilumab has to be over 150, and then reslizumab has to be over 400. And they differ in terms of like the frequency of administration. So that brings us to the type 2 low or type 1 high asthma treatments. The pretty much neutrophilic predominant inflammation. Many of the anti-IL-17s were studied. So far, according to the studies that I've seen, it's been disappointing. It's like there are no changes basically, but like further molecules are being studied. You have IL-6, IL-21, and 23 contribute to T helper 17 formation. They're being evaluated as a treatment for neutrophilic diseases, including things like Crohn's disease. Okay. And pretty much in summary, it's been a kind of a information-rich lecture. Just keep in your mind this. So you have allergic phenotype, which is like a part of the type 2 high phenotype or eosinophilic type phenotype. It would have high IgE levels, normal or increased blood eosinophils. Usually treatment is omalizumab. If you have eosinophilic phenotype, it's high blood eosinophils, normal or slightly high IgE, and usually treatments for that are anti-IL-5 and anti-IL-4, like mepolizumab, reslizumab. Non-eosinophilic, you would have low blood eosinophils, low IgE, mainly neutrophilic predominant inflammation. There are like certain experimental treatments, maybe bronchoscopic thermoplasty that's being studied, but still doesn't. So basically, again, this is a quick treatment algorithm. So if you have low eosinophils, high IgE, you can give omalizumab. If they have atopic dermatitis, usually dupilumab usually works well with that. If you have high eosinophils, high IgE, you can either use omalizumab. If they have like perennial allergens, if their BMI is high, then you can use reslizumab. If no, you can ask your patient if they prefer less frequent administration, if they have like a long travel to make. Usually benralizumab, and if it doesn't really matter, then mepolizumab. If you have decreased eosinophils, decreased IgE, maybe thermoplasty could benefit your patient, but again, it's sometimes it's, I wouldn't say experimental. From what I read on it, like it might improve the rate of exacerbations. However, it comes with its own risks, and there are like specific patient selections for that. Okay, thank you very much.
And the code for the following lecture is 43901. There's a question. Do patients have to be off certain agents for a predetermined amount of time prior to doing the blood test for the peripheral eosinophil count?
Not necessarily. So usually not necessarily. From what I found is that maybe if people are on corticosteroids, certain agents you'd look for, you'd be accepting like eosinophils over 150 in comparison to 300. But many patients, when they were enrolled in the studies, they were already taking steroids, they were already taking oral steroids, and then some of the studies evaluated if they can take off some of these medications going forward, but no, not necessarily.
Thank you.